To this pleasant morning. I'm Nakul Patel, Senior Product Manager. We at Emcure, we are the purpose-driven organization and which is dedicated towards offering effective medicine to cure patients and enable healthy living. And we at Acute Cluster, having FCM brands with the epitome of quality and success. Emcure has helped more than this 60 lakh Indian patients to rapidly correct manage deficiency anemia, and furthermore, we are taking pledge for making India iron strong. Today, Emcure is honored to have esteemed speaker Dr. PM Gopinath. And we are thankful, Dr. Gopinath, for giving us opportunity to host this scientific Meet the Expert webinar and be a partner for this wonderful academic educational initiative. Today, Dr. Gopinath sharing his view on real life scenario of usage of ferric carboxymaltose. Just I want to highlight one thing over here to all delegates that definitely our expert will address all the queries, questions, answers. One session get over. If you have any query doubts, please put in your chat box. That's it. Once again, welcome Dr. Gopinath, and over to you, Doctor. Dr. Gopinath.
Good morning. It is indeed a Monday morning, very busy schedule. You should be having a lot of activities for this. And I'm really happy to start the day with such important event. To talk about anemia, it's very common. And we know that it is not all that very highly advanced topic or a talk to be discussed. But however, when you think in terms of anemia, it is very, very important. Then we have to have certain good knowledge about treating an anemia, because if you treat anemia, you will be able to save half of the mothers from dying. That is the importance of this particular thing. So we will be talking on ferric carboxymaltose, 750 milligrams in the management of iron deficiency anemia. You will see this is a globe where you see that light color, no anemia. The dark brown color is anemia. If you look into this, you will see that anemia affects about nearly 800 million children and women globally. If you see the dark one, where the percentage is more than 60, you will see India is there. So that means every second woman, if you count about, if there are about 10 women in your room, every second woman is anemic. Then you can imagine the burden. Globally, it is about 41 to 56. That is, 1 out of 2 pregnant women are anemic. In India, the pregnant woman's age usually, even though we say the manageable or permissible legal age is 18, we do come across pregnancies as early as about 15. So here, the pregnant woman is predominantly between 15 and 49. The non-pregnant woman, in the age of 15 to 49, you say it is about 57%. All women here in India, 59.1% are the anemic. So whatever is your nutritional status, whatever is your improvement in educational status, whatever is your socioeconomic status, still anemia predominantly occurs here. Now let us see what is anemia. So according to the CDC, when the first trimester, that is 12 weeks, if it is less than 11 grams, they call it as anemia. Second trimester, when it is less than 10.5, we call this anemia. Third trimester, less than 11. But in a WHO, it just says less than 11 is anemic. Here again, when you just see the mild, moderate, and the various thing is given there. So hemoglobin in grams there. Mild, probably we call that 11 to 11.9. Moderate is about 8 to 10.9. And severe is 7. If you take the pregnant woman, it is about 1 gram less than that of the non-pregnant woman. So if you see the postpartum woman after delivery, WHO says less than 10 grams is anemia. FIGO says less than 11 grams is anemia. UK guidelines says 10 grams. So in all, you will see that they have to maintain a hemoglobin of more than 12, whether it is the first trimester, second trimester, third trimester, or pure postpartum. If you take the total iron requirement in pregnancy, you always calculated something like your savings bank account. This woman does not have a bleeding. Each month when she bleeds, she loses about 500 milligrams of iron. So by 10 months, if she does not get the periods, so she saves about 500 milligrams of iron. But however, you will see that in the first trimester, second trimester, third trimester, there is an increase in red cell mass, there is a growth of the fetus, there is a growth of the uterus, and there is a growth of the placenta. All put together, there is an increase in need. This need, first trimester, there is a very small increase, whereas you see here in the second trimester, there is a sharp increase in demand. So, and then after the postpartum, there is a decline. So this is the total iron requirement for a singleton pregnancy is approximately about 1000 to 1200 grams. You will always say, so the patient is eating well, she's taking iron supplements regularly as per the Mukt Bharat scheme of in our nation, but still, you know, all of them do not enter the pregnancy with a good iron reserve. So if you don't have a good iron reserve, your iron reserve will be depleted. So that is the reason there is a demand. What are the consequences of iron deficiency anemia? There is a reduced blood oxygen, which leads to the shortness of the breath. They are not able to climb the step. They become breathless, and there is a hypoxia, nausea. There is no weight loss. There is an abdominal pain. And then there is a central hypoxia causes headache, vertigo, lethargy, and some cognitive impairments there. The maternal anemia contributes to about 18% of the perinatal mortality, 20% of the mortality in South Asian countries. But if you take India, 1/3 of the women are dying directly of anemia or indirectly because of anemia. The pregnancy complications there is an increased preterm delivery, there is a premature rupture of membranes, preeclampsia, intrauterine death, intercurrent infections are very high in anemic women. There is an incidence of antepartum hemorrhage, and because of the severe anemia, there is a congestive heart failure. What about the fetal complications? Baby becomes low birth weight. Our normal birth weight is about 2.5 grams. So here kg, but here the birth weight will be less than 2 kg. There is an increased incidence of prematurity. And because of low birth and prematurity, there is an increased incidence of infection. There may be some congenital malformations, neonatal anemia, and abnormal cognitive developments there. So how do we make a diagnosis? Usually, as the patient walks into the clinic and sits in front of you, if she is breathless, then you know that she has to be anemic or a heart disease, one of the two. Most common is anemia. So it is not at all difficult to diagnose iron deficiency anemia. We do an history, we do a complete blood examination where you look for hemoglobin, RBC count, hematocrit, reticulocyte count, and these are all the data. Normally we take it. In an advanced study, we can just go for a serum iron, total iron binding capacity, transferrin saturation, all of them can be done. And if you see the iron ferrin, the cutoff is 30 microgram per deciliter to diagnose an iron deficiency anemia. You can always look at the peripheral blood smear, which will very easily tell you the iron deficiency anemia. Very, very rarely, you might have to go in for a bone marrow examination. The Anemia Mukt Bharat guidelines here, it just says mild anemia is 10 to 10.9. This is the first level of treatment. What you have to give is 2 tablets of iron and folic acid daily for about 6 months. And the parental iron, IV iron or ferric carboxymaltose may be considered as a first line of management in the pregnant woman who are detected to be anemic late in pregnancy, whom complications are likely to be low. So here again, if there is no improvement after the first level of treatment, and there is you have to refer to that higher center. The case may be managed by either IV iron or ferric carboxymaltose. If it happens to be a severe anemia, the first level of management will be immediate hospitalization in the 3rd trimester, where there is around-the-clock facilities are available. Treatment will be using an IV iron sucrose or ferric carboxymaltose by the medical officer under the supervision. What are all the indications of parental iron therapy? We always feel that parental iron therapy is good. So, but what are all the indications of iron therapy? Failure of oral iron. We have 9 months. In that, first 3 months is very important. Second 3 months, there is a cognitive and brain development. Third 3 months is the weight gain. We cannot wait for 9 months to say that there is a failure of oral iron, because by the time enough damage would have been done on the thing. Within a month, if you feel that there is no improvement with the oral iron, you just have to go in for parental iron. There is a non-compliance or intolerance to oral iron. When they say they are having a nausea, vomiting, and they are not able to tolerate, immediately you have to switch over to the parental iron. The late 2nd and 3rd trimester with moderate to severe degree, you have no time to build up the hemoglobin. Because of that, you just have to go in for parental iron. When you need a rapid rectification of anemia and replication of iron stores are expected, then you have to give parental iron. And when there is a malabsorption, whatever amount of iron you take, it is not going to be absorbed, then you have to go in for parental iron. If there is a bleeding diathesis, when the hemorrhage is likely to continue, you can't wait for an oral iron. You have to just directly do it. What are all the contraindications? Gestational period of less than 12 weeks. That is the first trimester. It is not an absolute contraindication. It is a relative contraindication. Sometimes even at 10 weeks, if there is a very severe anemia, you can just go ahead and then give it. Lack of facilities for resuscitation, again, is very, very important. And known history of anaphylaxis or reactions to the parental iron, you should not try to do it. Known state of iron overload there, then you should not have. There is a very few contraindication. IV iron therapy is always superior to oral iron in terms of the speed, absolute extent of the rise in hemoglobin, and replenishment of the iron stores. You might only be looking at the iron hemoglobin, but you also have to look at the iron stores. Then how did this parental iron start? So you will see here, they all attempted right from 1932. Then they started iron saccharides, and then slowly it came to the first IV iron paper was published in the US, and then came low molecular weight thing, then dexferrum, then ferric gluconate, and iron sucrose, which became a predominant change in 2000. Then ferromoxetol in about 2009. The revolution has come in 2013 in the form of ferric carboxymaltose. So even in 20, iron isomaltoside is also being used, but predominantly the most safer molecule will be an iron ferric carboxymaltose. The parental structure of iron and iron carbohydrate here, there is a carbohydrate. You will see that it is a shell. Within the shell, there is an iron oxyhydroxide core. There is a rapid release of large amount of labile free iron, which leads to the toxicity. So it has to be very slowly released, but it shouldn't be too slow also. The currently available ions are the iron carbohydrate molecules on a spherical success. What actually happens is the core of iron is surrounded by a carbohydrate shell. A large and more complex carbohydrate shells of new iron allow controlled release of iron from the core. So they mitigate the release of the labile free iron. So this allows administration of large doses of IV iron in a single short time. So there is a carbohydrate shell, which is very, very important, which protects there. What are all the properties of the ideal iron parental? You will see that iron dextrose is there, and then iron sucrose is there, ferric carboxymaltose is there, and then the first column shows what should be the ideal. So you will see that if you take the half-life and the 3 to 4 days in an iron dextron, 6 hours in an iron sucrose, 16 hours in a thing which is ideal. pH is almost near neutral. Osmolality is isotonic. Antigenicity, which is very, very important for you to have an anaphylactic reactions there, is very low. Test dose, do you need a test dose? Here, absolutely no need to give a test dose. Time for injection, hardly about 15 minutes for 1000 microgram. The maximum dose, we normally give up to 1000 milligrams. So this is a very, very ideal when compared to all other forms there. So the classification, depending upon the type of the complex here, the type 1 complex is very strong thermodynamic property, ferric carboxymaltose and iron isomaltoside and ferrimaltoside and iron dextron complex. The type 2 complex, which is moderately strong, is iron sucrose. Weak components are iron gluconate, iron citrate, and iron sorbitol. So if you are looking for a good stability and then probably a good thermogenic property is very important, where you can just choose ferric carboxymaltose there. The parental iron preparations, the first generation is iron dextron, and then you have a low molecular iron dextron, ferric gluconate, iron sucrose, and these are all the newer innovations. I have been in the field of obstetrics and gynecology for about 45 years. So we all started with an iron dextron where it will be in the form of 100 milligram. You give one shot intramuscular, patient will feel better. Second day, she will limp and come with the joint pain. Third day, she will come with the fever. And fourth day, she will come with the green color patch where you have injected. So this is a very classic thing, It is very difficult to convince her to take the full dose. So this is how the first generation came. Then iron sucrose came, where we were able to do it very comfortably. Then after ferric carboxymaltose here, all you need is to just send a prescription. Our trained staff nurse will take care of the entire administration. It is that easy. What about the limitations of parental iron preparation? Iron dextron it is associated with severe allergic reaction, which leads to anaphylaxis there. If you take the iron dextron low molecular, it is again non-fatal severe adverse reaction, allergic anaphylactic reaction. We have to give a test dose and then wait, and then you have to give more than 1 hour of IV infusion, which is very, very important there. Ferrigluconate, it is only approved for the treatment of iron deficiency anemia in chronic renal disease. And when they are going hemodialysis, they are just using it. It can be administration in low doses with a highly free iron release, and multiple clinical visits are required. They have to keep on coming there. Iron sucrose can be given in a low dose or associated with very high labile. So clinical visits or multiple clinical visits are required. So if you look into the fermoxetol, it is only approved for iron deficiency anemia and CKDs there. There again, it is it's a maximum allowed single doses compared to other third generation there. Iron isomaltoside contains high amount of labile iron with the third generation. The risk of hypersensitivity is very high. So if you take ferric carboxymaltose, safe options of higher dose, 1000. I have used this even in the first trimester. I have used it in an IVF and IVF pregnancies, very safe and very comfortable. And I have a very long lasting experience on using this ferric carboxymaltose of 1000 grams altogether. It is a type 1 dextron-free, robust iron with a long half-life of more than 16 hours. It is a stable complex, does not release non-transferrin bound compounds because there is no allergic reactions there. Structure is similar to ferrin, deposited easily into the reticuloepithelial systems there. Low antigenicity, there you don't need a test dose at all. So this is very, very important part. So what are all the critical attributes of ferric carboxymaltose? The type 1, it's a robust parental iron. It is not associated with dextron-induced hypersensitivity. Can be administered even as high as about 1000. Short infusion time, within 15 minutes, the iron is released slowly, avoiding the toxicity and oxidative stress because there is a carbohydrate shell around it, and structure is similar to that of ferritin. It is easily deposited in the reticuloendothelial system. Test dose is not required. It is a very low immunogenic potential. The qualities of ferric carboxymaltose are best suited for a real life clinical usage there. So it has also come into the 750 3Ds. What is the 3D? It is a dose, dilution, and diuretic. So here you just have to look into that. When the hemoglobin is less than 10, when the weight is below 35 kg, you give 500. When the weight is between 35 and 70, you give about 1500. And more than 70, you need about 2000 milligram. So when the hemoglobin is between 10 and a little above, then you can more or less go for the same dose. Whereas in moderate weight, 1 gram, and moderate more than 70 kg, 1.5 gram. This is the ideal dose calculation based on the BMI. This is very, very important. Whatever you do, this is the very important thing. So dilute that ferric carboxymaltose in about 250 ml of normal saline. So once when you dilute it, this should run within 15 minutes. You cannot start the drip, continue to do your work, go back after 2 hours to see whether it is going. Because the adverse drug reactions of thing are potentially related to the long duration of administration. You have to dilute it. Once when you dilute it, within 15 minutes, it has to run. So this is the major thing, instruction which we have to just give thing. Dilution of a ferric carboxymaltose in high volume of saline beyond recommendations provided in the prescribed infection is not permissible. So you can't, just because you want to avoid allergic reaction, you can't put it in 1 liter of, 1 liter of a normal saline or 1 liter, half a liter of normal saline. It should be exactly about 250. What I strongly suggest, either you discard 250 ml and then start your iron, or if you feel the patient is not severely anemic, cannot overload, then start the IV fluid, make sure that it is running normal, and then at exactly around 250, you can use the molecule to dilute it there. The possible mechanism why it happens is long duration of administration and excess dilution may lead to the destabilization of the iron complex. So that there has to be a constant release, and then it has to be a stabilized iron complex for a safety. So that is the most important thing. How do we monitor there? It should be monitored when the staff trained to enough to manage anaphylactic reactions. Always keep an anaphylaxis tray ready. You keep an iron, along with the iron, you just keep the saline, and then keep one Avil, one Decadron, or a hydrocortisone, and this has to be kept there ready. You should not be running. And then this facilities should be available. You can't do it on an OPD basis when you are busy. Patient should be observed for effects at least about half an hour after the FCM. It is very easy, very simple, and it is monitoring is very easy. Where do you give the place of iron therapy? The majority of the Indian patients are anemia, and their weight is somewhere between 35 and 70. So hemoglobin is always less than 2. So here the doctor can dose either 500 into 3 injections, 3 hospital visits, or 750 into 2 injections, where it will be 2 visits, or 1 gram. So the moral of this story of the slide is you should minimize the hospital visits. The same time, you should not give more than 1000 milligram per visit. So that is how you just have to schedule it there. So this is the place of iron therapy there. And if it is less than 35, you say the cumulative dose is about 500. First day, you give about 500 FCM. And do you require the normal thing? More here, the normal saline, about 100 ml is enough for a 500 thing. Here, more than 6 minutes duration, 15 minutes is ideal. And if it is between less than 35 with severely anemia, then you give it in a 100 ml saline and then run for about 6 minutes. If it is the normal moderate weight, so if the cumulative dose is about 1500, use about 750 on after 7 days. First day 750, after a week 750, 250 dilution, run for about 15 minutes. If you are using the 1 gram, no necessity for a repeat dose. Normal saline 100 ml, you can run it for 15 minutes. So if it happens to be something like, if you are going to use a 2 gram, ideally it is not recommended. But you can use it if it is a very severe anemic woman, obese, where you will be able to use it with about 250 ml. So this is the place of therapy in the chart where we have to do it. Now let us see what are all the clinical evidence of FCM 750 in the management of iron deficiency anemia. This is a paper which published. They have taken the study of the participants, condensing the patients are at least 18 years of age who have been screening for a hemoglobin value of more than 11 with the ferritin level not more than 100. This is a target that they have just taken. The objective is to primary efficacy endpoint, change of the highest hemoglobin value from the baseline to 35 days. All causes of mortality, non-fatal and non-stroke, they have taken as the safety endpoint. This is where they have looked at. The key findings in that particular study, you will see mean hemoglobin rise was significantly higher in FCM than the oral group. So compared to about 1.5 grams versus 0.8. That is only half was achieved by oral iron, whereas double was achieved with the parental iron. Significant increase in the hemoglobin on the day 5 in this FCM group. You will see that it is 2.9 gram increase in this FCM group. Safety endpoints were patients receiving FCM 16 out of 96 when compared to the thing. It is a very mild reactions was seen. Probably they've just think it. Conclusion is 750 milligram FCM doses are safer and superior to oral iron in increasing that. FCM administered on 2 infusions, 750 milligram given 1 week was safer and effective, should be the treatment of option for iron deficiency anemia in patients who have an unsatisfactory response to oral, as well as those who are intolerant to unsuitable for oral iron. So this is again one of the David Brigham's study where they have 2 open label randomized placebo controlled trial was conducted. What is placebo controlled trial? On one arm, they will give the drug, and the other arm, they will give a placebo. So in a single 366 women, they have just given weekly, or here there is nothing was just given. So the key findings was there was an increase in hemoglobin and iron indexes occurred on the FCM group versus the placebo group there. So in the multi-center study, 2 infusions of FCM was needed to reach the target versus 3 to 5 intravenous iron competitors. So that means only 2 infusion is good enough when compared to that. So the conclusion was intravenous FCM is safe, well tolerated, and then improvement in hemoglobin iron indices were comparable with a single dose of 750 at a rate of about 100 milligram per minute. That is, when you run it in a 250 ml of saline for about 15 minutes. Few FCM infusions were required to reach the target iron compared to the other preparations. You don't have to wait and then give every often. 1 or 2 is more than sufficient. There are some global evidence of FCM in pregnancy. So they have 11 studies. They have just seen it from different countries, which is highlighted here. There's about 2,495 pregnancies. Highest hemoglobin rise was seen in about 3.6. Highest ferritin level was seen in about 188 microgram. In Indian study, there are about some 21 studies comprising of about 2,685 women, where they have seen the highest hemoglobin rise was about 5.5 grams, something phenomenal. And the highest ferritin level was seen in about 180. So current evidence highlights the data of FCM use in altogether 5,180 pregnant women with a maximum rise of hemoglobin to 5.5 grams per deciliter and ferritin level of about 1,180 microgram there. This is another Indian study where the safety and efficacy of ferric carboxymaltose in the management of iron deficiency. It's a randomized, multicentral, real-world study from India. It was published in June 2002. So in this particular study, you will see here, so they have seen the improvement in the hemoglobin, in the mild anemia, moderate at the baseline, and then you will see at the thing, there is an improvement in serum iron. You will see that all the reds shows there is an improvement, and at the base levels are shown in the blue level. So this study very clearly says that there is a very good improvement of that. So this is another study in the management of iron deficiency anemia in the pregnancy, where the real world study, 1,191 pregnant women were seen in Prakash Trivedi's group, where they published it in the November 22. So here again, you will see the anemia, the blue one is at the base level, red one is what they have achieved in the improvement. You will see in almost all the group, moderate anemia, you will see from the baseline, there is an improvement of about 2.8 grams of deciliter of hemoglobin rise, ferritin level of about more than 30. This is another study. So this is an Indian study where you will see that 271 women in the second and third trimester received FCM. There was a significant hemoglobin rise was seen in about 20 days, which is phenomenal. And you will see that increase in hemoglobin was 4.2 ml. So single dose of administration of FCM, a rapid rise of hemoglobin to moderate to severe anemia in a real-time scenario is noted from this particular study. So this is another study where you will see that the data on 271 women received about 1,000 micrograms of FCM on vital parameters there. So you will see here that it is absolutely safe. There is no problem at all. I can vouch for this because in my center, what normally we do, we write the prescription, our trained lip, what staff nurse will give. Before you finish another 2 consultation, that patient will walk in and say that she is completed and she is fine. That is the real world scenario. All the changes has been monitored there. What about the neonatal outcome? This is a study from Sanjay Gupta's group where about 162 newborn mothers were delivered after the FCM were analyzed for mean gestational age at delivery, mean birth weight, Apgar score, stillbirth, perinatal and neonatal mortality, and requirement of hospitalization there. So on the global scenario, neonatal outcomes, the weeks of pregnancy at delivery, global score, the Apgar scores, birth weight, neonatal resuscitation complication were not adversely affected due to the FCM. In fact, they have improved it there. How is the management of iron deficiency in postnatal? After the delivery, you can't write off that mother and send her home. As per the guidelines, the postpartum anemic patient, if you do not improve the anemia, one is she succumbed to postnatal infections. There is a poor breast milk secretion, poor nutrition to the baby. Baby goes in for a severe growth retardations, and baby goes in for anemia. It goes for a hyperbilirubinemia, and then it goes for all the infections. So it is our duty, not only ends at the delivery, also up to the postpartum period, we have to make sure that they do it. There is whatever is the pre-iron level, at the time of delivery, you know that there is a certain amount of blood is lost. So in order to make sure, it is best to administer a bolus of, in the postpartum period, the correction of anemia is most important there. The key recommendations from 2019 UK guidelines in the management of iron deficiency anemia, there they say women with less than 10 grams within delivery of 48 hours who are hemodynamically stable, then you have to give it. Use of IV iron preparation should be considered with women who are previously intolerant or they did not respond to the oral iron. So this is a very, very important thing. There is a supplementation of interventions by the Ministry of Health there. Even in the children, they just say that you just have to give the oral iron in the following day. So the moral is, when you are treating a pregnant woman, 100 milligrams of elemental iron and 500 micrograms of folic acid has to be given for 100 days. That is, the first 100 days only folic acid. The next 180 days, iron and folic acid. If not, at least in the last 100 days, you have to give iron and folic acid. So this is a very important message. Blood transfusions and parental iron. Previously, we always, even as a student, we always used to run between the blood bank and the labor ward because we used to give so much of the infusions there for the lack of the parental iron therapy. So there are 10 commandments for the transfusion practice in medicine there. Benefits outweigh the risk there. Today, it has to be thing. There are a lot of risk involved. Unless it is absolutely essential, we do not go for a blood transfusion. With signs of shock, acute hemorrhage, and signs of hemodynamic instability, you go for a blood. And if it is a very severe anemia with less than 7 grams, symptoms of hemodynamic alterations, you go for an iron. During the antenatal trial, a trial of FCM to be given to all the mothers presenting with severe anemia. Studies from India identify postpartum hemorrhage is a major indication for the in obstetric practice, and IV iron FCM can be an alternative to blood transfusion, especially in women with a high risk of transfusion-associated reactions. Availability of the blood is an important factor, and then avoiding infection like HIV and other things is an important factor. There is a scare in the patient, so we can outcome that. What about the safety and efficacy of iron therapy, reducing the requirement of blood transfusion there? So they have done about 72 studies from 66 to 2013, including about 10,605 patients requiring quantitative outcome of data and analysis. Most changes in the hemoglobin concentration and the risk of allogenic blood transfusions was taken there. The key findings is intravenous iron was associated with an increase in hemoglobin concentration, difference between 6.5 grams per liter, 95% confidence into the interval of 5.1 grams, and reduced risk of requirement of blood transfusion. Intravenous iron is effective in increasing the hemoglobin concentration and reducing the risk of allogenic red blood transfusions there. So here you have an Orofer FCM 750, which can be safely given in weeks apart, which can very comfortably just be given with about 250 ml of saline run to 15 minutes there. So there is a lot of percentage of elemental iron in FCM brands which has been taken there. You will see Orofer FCM has got the highest possible percentage there. And the dose, as we have mentioned it is very important. When you use a smaller dose on a thin woman, you can run it in about 100 ml. When you use it on a moderate woman with a moderate anemia, run it at 250 ml. And all this has to be run between 8 minutes to 15 minutes. You should not mix it up, keep it, and then use it after half an hour and run it for 2 hours. That is the most important point which you have to drive at the thing. To conclude, ferric carboxymaltose is an ideal parental iron. It does not require test dose, low risk of hypersensitivity reaction or anaphylactic reactions. FCM dose are calculated based on the body weight and hemoglobin deficit. However, the hidden point is we do not calculate the iron stores. The most Indian patients are between 35 and 70 and average hemoglobin of less than 10 grams. These patients will require about 1,500 microgram, and lower dose may not be therapeutically useful. Significant increase in the hemoglobin and blood indexes is seen with a trial of 750 milligram compared to other treatment option. So FCM 750 offers flexibility for doctors to choose various parental iron preparation for the treatment of iron deficiency anemia. Thank you very much for your patient listening. I'm free to ask any doubts regarding this.
Yes, sir. It was a really wonderful session. Means everyone they understood the basics of anemia. They understood the basics of ferric carboxymaltose, and I'm happy to share with you that more than 1,000 Emcurians they have joined, and they are they are on live stream. That's very important. Doctor, few questions we have received in chat box. Just I'm reading. One question from Mr. Golam Khan. The question is, what is the role of molecular weight in parental and how it will affect on its efficacy?
Before you come to that question, there is one question from Sridhar.
Yes.
Sir, recently FCM published ASRM, how we can establish the molecule in IVF segment. Even before the publication of ASRM, I have been using FCM in an IVF segment. When the patient comes for the stimulation, if the basal hemoglobin is less, I don't wait for her to improve the hemoglobin and come back for the IVF. The very second day, I give a total dose of FCM 1000, and then I just start the stimulation. That is one. Second is, when we do get oocyte donors, when we get an oocyte donor, when the donors are always anemic. So in that scenario, we don't wait for them to just increase the iron and then come back after 2 months or 3 months. So immediately we give them FCM iron and then just go for a stimulation. By the time when the patient comes for a pickup, within about 2 weeks, she is able to stabilize it and there is no post pickup infusions there. Then another thing is when the patient has got a pickup and then she comes back after 2 months for a frozen embryo transfer. And that time we always do the basal studies on second day. So in the second day, if there is a fall in hemoglobin, we do not waste time. We just give an IV infusion of 1000 and then we start the FET protocol. And by the time on the 19th day or 21st day for a day 5 embryo transfer, when it comes, then it will become very, very easy. That is my personal experience, even before the ASRM guidelines.
Right, sir. You rightly mentioned, sir, that before pickup, you always prefer FCM 1K, that is strength is 1K. So is there any role of FCM on oocytes?
No, FCM has got no role on oocytes because the half-life of an FCM is only 16 hours. So
Right.
what you just give it, so you give it on the second day, whereas you do the pickup on the 14th day. So there is absolutely no impact of FCM on the oocyte thing. In fact,
Absolutely,
you will be able to get a better quality of oocytes because the basic anemia is corrected.
There are the few articles recently I have read that they have mentioned that ferric carboxymaltose, they improves the oocyte quality, means
Exactly.
that improves the granulosa cells and theca cells.
Yeah,
So
that improvement, either it could be direct or it could be improving the basal nutritional value of that mother by which they're giving it. But I have seen it, and that is the reason we have been following it.
Right, sir. Yes, sir. Shall we go for another question? Means next question.
Yeah.
Yeah, that Mr. Gulam Khan, he asking, what is the role of molecular weight in parental iron and what is the effect means on efficacy?
See, the molecular weight of the iron is very, very important. And if it is a higher molecular weight, that is more prone to produce a lot of adverse side effects. So that is why whatever is the prescribed molecular weight of that particular molecule, I mean, the preparation, what you do, you have to be there. So this is where we feel that spurious preparations comes into the thing with a higher molecular weight, producing a lot of adverse reactions there.
Correct, sir. Absolutely. Sir, you mentioned during presentation that more labile iron, that means which causes the reaction, which causes the adverse drug reaction. So the available preparation like isomaltoside, that isomaltoside, as per the many articles, they have mentioned the isomaltoside has more labile iron. Still, but doctor using that isomaltoside molecule. So how we can justify supplements?
No, the importance is the iron release is very important. See, it has to be released at the appropriate time, not early, not later. So that is the important thing. So here, that is why we specifically mention it. It has to be diluted It has to be given in a prescribed time for it to, the carbohydrate molecule dissolves, and then there is a release of free labile iron. The free labile iron total concentration is not important. The way in which it is released is important.
Right. So there is a message from Mr. Sridhar. That message from Emcure that need your academic support for establishing FCM 750 in peripartum anemia awareness in India. So that's your support is required.
Yeah, see, we see almost all the patients in our thing. I can boldly say the entire pregnant population, iron stores are depleted. They might come with a good iron, say 11 grams and 12 grams, but they are depleting the iron stores and giving you 11 and 12. If you go through the iron store, their iron stores will be very poor. So with this poor background, when they go through the pregnancy, obviously, they sort of lose blood, minimum of 500 to 750, they do become anemic. Even if they are not anemic, if, for example, they come with 12 grams and they come to 10 grams, that means they have a depleted stores with 10 grams. So ideally, on all the patients who have had episodes of anemia during the antenatal period, I feel that they have to be given a single dose of 750 and then send them home after delivery.
Right. One question from Mr. Madan is asking that how we can differentiate blood transfusion versus iron infusion.
Yeah, see, there are a lot of things there. First is, if you're, I will take a case scenario. A pregnant patient coming at 24 weeks of gestation with 8 grams hemoglobin or 7.8 grams hemoglobin. So I have an option to give blood transfusion. I have an option to give FCM. If I fall into the blood transfusion, first of all, I have to get a blood which should be cleared of all the infections. It should be screened, and it should have been kept, whoever is that, the window periods has to be just completed. And then that lot of issues on other related infections and anaphylaxis are there, which I have to risk it at the 24 weeks of pregnancy. However, when you balance the adverse reactions of ferric carboxymaltose there, I might have to give 3 doses or 2 doses. So from 7.8, if I have to bring it down to around thing, I might have to give 1 grams. So, but the adverse reactions and the anaphylaxis and then all that put together, it is very, very simple and easier. That is one. Second is availability. If you have to have a compatible blood, which is screened and selected, it's going to be a difficulty. Whereas you here, throw your prescription to your pharmacy, prescribed pharmacy, and get it back in 10 minutes. So that is this availability. The third is a blood transfusion. When you give, the blood has to run for minimum of about 4 hours. And then after that, anaphylactic reactions, if it is there, it comes in the first 24 hours. So that means you have to keep the patient under observation after a blood transfusion for a minimum period of 24 hours in your hospital. Whereas here, I run it for 15 minutes, walk them for 15 minutes and send them home. The hospitalization time, patient's time, patient's attenders time, all that put together. And this is where you have to pitch in the difference between the ferric carboxymaltose infusion and the blood infusion. Am I clear, Madan?
Yes, doctor, clear. Thanks for sharing your knowledge.
You mentioned that for blood transfusion, patient need to admit 24 hours. And for the FCM, it's only means that observation is required only for 15 minutes. That's very important.
See, to be very frank, when FCM was started, I was in one of the advisory board meetings also, where I differed. In a case of severe anemia, you have to go only for a blood transfusion. You should not go in for a ferric carboxymaltose. But over a period of time, with my personal experience, even in a very severe anemias, I have given multiple doses of FCM and come out of the problem without a blood. Now I'm very confident that I can avoid blood transfusion if I have a time when the patient is not in a hemodynamic shock. I will prefer only a FCM.
Sir, one question from Mr. Dheeraj. He's asking, one of my doctor is using 500 mg FCM in 250 NS, and he's taking time almost 30 minutes. So means without any adverse effect. But we are always talking the calculation of relative dose of iron dose. That if 500 mg is there, so we need to take 100 ml solution, NS solution. So, but doctor is taking almost 30 minutes for 500.
You have to advise them strongly not to do it, because all through they must have got away with that. But sometimes you will get an anaphylactic reaction that will have a bad impact on us. So we have certain norms. The dilution is very important because the concentration of the iron with which you have to give is ideal, most logical, and most suitable. If you are going to dilute it and run it for a more time, you are giving a chance for the release of antigenicity, and then the anaphylactic reactions are supposed to be more in that particular group where you have given it for a longer time.
Sir, one question from my side, sir. How do you diagnose if patients having unexplained anemia? So how you diagnose for that?
No, the first important thing is we have to establish the diagnosis of anemia. How do we establish the diagnosis? The simple thing is iron, hemoglobin concentration, and total ferritin level, and then peripheral smear. So once when you establish the cause of anemia, we have to find out, I mean, they established anemia. The second step is to find out the cause of anemia. It could be a loss of store. It could be a nutritional. It could be an iron depletion. So if there isn't going to be an iron depletion, unless you find out that cause and correct it, however amount of increase, for example, it's a bleeding piles or a bleeding gastric ulcer, then however you try to do it, it is not going to be effective. There may be an hidden malignancy. So you have to make a thorough clinical examination, spend some time with her on all the aspects, and then probably you will be able to just establish the cause of anemia. Then start correcting the anemia. You will be very comfortable. You will be successful.
That means we need to identify the root cause. That is the proper diagnosis we need to do. Yeah, sir. Any question from faculty?
Sir, this is Sridhar from Hyderabad.
Yes, sir.
Sir, can we, with your support, can we make an algorithm for FCM is 150 and vitamin B12, deworming, and folic acid? Any useful, sir? Increase any awareness?
See, the oral iron, when you give oral iron, the absorption is improved by a vitamin C. See, whenever I give oral iron in the form of a tablet to my pregnant patient, I always ask them to space between the meal, not after the meal, not before the meal, space between the meal. And I ask them to take it with the citrus fluid, something like the orange juice or a lime juice, because the vitamin C in that increases the absorption. However, when you are giving parental iron, you don't have to load them with vitamin C before a parental iron.
Thank you, sir.
Anything else? Yeah, sir, it's already we are concluding this meeting. And this session, I'm going to hand over to Mr. Anil Pillai and Mr. Nikhil Manas.
Sir, good morning.
Morning.
Sir, I must say a sincere thanks to you on behalf of entire Emcure. So because of your, valuable talk today in the morning, which I personally requested you while, I met you, almost close to 1,000 people are listening you, sir, from the entire Emcure team. And the way you have explained the benefits overall, rather, it's not just benefit of FCM, the overall journey of anemia to, the advantages of MCM. It is going to have a big help to all of us. So thank you so much for your valuable talk, sparing your valuable time early in the morning, sir, and talking to the whole team of Emcure, which means a lot to us. And whatever, we were listening you, whatever way you have explained it, it is going to have a big help to all the teams, sir. So the entire team of Emcure is going to have a lot of benefit after listening you. And I believe that surely now their science discussion will be a way ahead, after today's talk having with you, sir. So thanks a lot, sir. Thank you very much.
One message to all the team. Pregnancy, patient become pregnant, some of them die, right? That is the maternal mortality. Pregnancy is a normal physiological phenomenon. Just like how you grow up, it is a physiological, it is not a disease. A pregnancy is getting pregnant and delivering is a physiological phenomenon. Strictly speaking, no woman should die of a physiological phenomenon. But still, there are a few dying of physiological phenomenon. But for pregnancy, we need a man and a woman. What factor we contribute in preventing that pregnancy complications like complications and mortality? So let us, the Emcure team, just contribute its best to see that we do our duty to see that we save the mothers.
Thanks a lot, sir. Point well taken. And, on behalf of Emcure, we assure you, sir, we will surely together work on this cause. So thanks a lot, sir. Thank you. Thanks, Madan, for helping us getting sir over here today. Yeah. Because
my pleasure,
listening to sir, means, a lot of difference while, sir is speaking to our entire team. So, sir, thank you. I'll be personally coming again to Chennai to meet you, and thank you in person as well.
Thank you.
Yeah.
Thank you. Thank you all. Bye-bye.
Looking forward for more such talks with you, sir. Thanks a lot. Yeah. Bye-bye, sir. Thanks, Anil, Sridhar, Madan, Nakul, RX team, for the...
Please stop.